Hello, hello, hello. We are live for another episode of Wellness Wednesday with Dr. Latoya Wells. I have my colleague and friend here, Dr. Dr. Amma Seewah-Bonsu. Just want to give you a brief overview of who Dr. Amma Seewah-Bonsu is. She's a nurse practitioner, a transplant coordinator. She's a kidney transplant provider at the Orlando VA medical system. She's also a board of trustee member of the National Kidney Foundation of Florida. Dr. Bonsu, welcome, welcome, welcome. I'm so grateful to have you here. We tried to do this last week and we had some, technical issues, but it's all good. And we're going to move forward with tonight. We are closing out the discussion on Kidney Awareness Month and kidney health. And who better than Dr. Amma to come on and talk to us about this? Is the individual that I've been talking about the last couple of weeks during our Wellness Wednesdays about this person who is a kidney specialist. And so I'm so grateful to have her here. Thank you so much for being here. I can't hear you.
Thank you for having me.
There you go.
Oh, there we go.
All righty. I am so grateful to have you here. And so I know March is the month that we highlight kidney health and kidney awareness, but this is something that you and your patients live day in and day out, right? Kidney health. Tell us a little bit more about you and what you do, and then we'll just kind of dive into some more discussion.
Sure. So I'm Amma. I am a nurse practitioner at the Orlando VA Health System. And my primary job there is I am the transplant coordinator. So I coordinate all the transplants from liver, kidney, heart, lung, even intestinal. And I also, my background is as a dialysis nurse. So when I graduated from NP school, it just seemed logical that I would go straight into nephrology. So I am also the kidney transplant provider for the Orlando VA.
Cool. That's amazing. When she and I had an opportunity to spend some time together a couple weeks ago, right? Maybe almost a month ago now. And we were in her car driving to a destination, and we had some very interesting conversations and just kind of talked a little bit about what she does. And she's very passionate about this. And to start out as a dialysis nurse and bring that into your higher education and your nurse practitioner and even your doctorate is amazing, because as the month of April is Minority Health Month, right, where we highlight minority health. And so how befitting that I'm speaking to, African American, or African, actually, not even an African nurse practitioner that specializes in kidney health. I know for me, I just wanted to be a nurse. But then once I became a nurse, I wanted to do more. And family practice and internal medicine was the way that I went, because I just loved it. I get to see pretty much everything. And so do you. You serve a special population of patients and individuals. And so tell us a little bit about your patients and who you serve.
Sure. Well, I have the honor of serving veterans, and it is very humbling. I'll be honest with you. When you're sitting across from a patient and they tell you, for example, they're a prisoner of war, or they were a prisoner of war, or you're sitting across from somebody who has Purple Hearts. I don't know if I mentioned this to you, but like one of my proudest days at the VA is when I actually got to meet a Tuskegee Airman. That's something that's still kind of I'm still kind of blown away. Like I actually got to meet that individual. It was the coolest thing. And along with serving the veteran population, of course, they come with their own special set of health issues. I have mad respect for the veterans, because just the fact that they actually signed up to serve this country says something about them.
Right.
And so our goal at all the VAs is to provide them with the best service we possibly can. So sometimes things are a little bit, it is a government entity, and sometimes, we do things a little bit differently, but I like to think we get things done. And I like to think that we have excellent outcomes.
Yeah.
We do, and we have another friend. I believe you spoke to Shelly already. So Shelly's kind of my counterpart. She
Yeah.
manages other liver transplants, and it's just amazing to watch when you see somebody come in, very sick, and then we have that ability to turn their lives around. It really is a special place. The VA is a special place.
Mhm.
um, Sometimes we don't get the best press because sometimes things, we don't necessarily always think outside the box, but I can honestly say that the people I work with, my colleagues, our goal is to serve these vets the best way we can.
Thank you for serving those who served our country and served and who gave up their lives and their time for us. Many who lost their lives, fighting for, things that we have right now and the freedoms that we have. So thank you so much for that.
Thank
Tell
you.
me a little bit about kidney health. In my previous lives on National Kidney Awareness Month, we talked about, what the kidneys are. We talked about some of the normal ranges, things of that nature. What are you looking for? And I know you're on the other end of things when it comes to kidney health with transplants, but walk me through the progression of a patient leading up to you. What are some of the things that you guys look for, even as a dialysis RN, and just taking care of the kidneys, right? And
Right.
nephrology in and of itself. Walk me through that process.
Sure. So most of our patients that come to us, as yeah, I'm sure you discussed, the number one cause of kidney disease slash kidney failure in the United States is currently diabetes, followed by hypertension, and there's some others that are a little bit less common, but those are the two big ones. So what we look at is that you're getting a patient that, hypertension is so interesting because, we call it the silent killer, and it truly
Yeah.
is.
Yes.
Because, you might have like a slight headache and you really don't think anything about it, and you might not get your blood pressure checked for a while. And then how many times have you seen a patient that is walking around with a blood pressure of like 220 over 100, and you're like, how are you walking around?
Yes.
And so the best analogy I have when it comes to that, especially, is if, with high blood pressure, it's like the kidneys are, like, I consider them rocks, and high blood pressure just chips away at the rock, being the kidneys, and that leads them to kidney disease. With diabetes, it's really interesting because the same thing that causes, like, we have patients who have neuropathy, the numbness and tingling in their feet, and then they also have the retinopathy where they have the bleeding in
Yes.
the eyes.
Yeah.
Is very interesting, and I think that's why we all love medicine, is because the same vessels that you have in the eyes are the same vessels that you have in the
Yes.
kidneys, so you are going to have damage from diabetes. So
Yeah.
what do we see the complications of diabetes. Unfortunately, we see the complications of high blood pressure. A lot of our patients come to us, and I'll be honest, a lot of people say, I didn't know anything was wrong with me. I
Right.
had no idea. But unfortunately, when they get to that point, one of the questions we ask our patients, especially as they progress in kidney disease, is, does the sight of meat make you sick?
Mm,
Because they get what we call uremic, where they have the toxins build up in the body. Because, like, as we know, the kidneys basically get rid of the poisons in our body from everything we eat
yes.
and drink, right? Our bodily processes. But when you have a buildup of that, you literally have a situation where you have so many toxins in your blood. One of the biggest telltale signs is that the sight of meat makes people sick. Like, they will stop eating meat because they're like, I just can't stand the smell of it. The other one is that you'll see a lot of people just, they're itchy. They're itchy, and you're going, and they're like, I don't know why I'm itching, and I've used this new lotion, and this lotion is not working. And
Hmm.
it's because we have something that's called phosphorus in our body, and our when the kidneys go, you lose the ability to get rid of that phosphorus in your body. It
Hmm.
accumulates and it makes you itch. So, we look at so many things. Another thing we look at is, we look at, people are cold. Have you, and like, they'll tell you that they're cold, and then on top of being cold, sometimes they do something where they can't stop eating ice. And you're going, you're cold and you're eating ice. Well, that's a sign of anemia, because the
Yeah.
kidneys also kind of make a hormone that help us produce red blood cells.
Hmm.
So it's really an interesting process. The kidneys are kind of in charge of, they're in everybody's business, as I say. The
Yeah.
kidneys are in everybody's business.
Yeah.
So sometimes it can just be the most nondescript symptom, and it could be kidney failure.
Yeah. So the symptoms that you just talked about were some of the things that I discussed, but I love the way that you were able to break it down and put your spin on it because, again, this is something that you see each and every day. When we're looking at the blood vessels, and whenever I talk about diabetes and high blood pressure and the pressure in the vessels, how it causes the damage to those tiny blood vessels that lead to the eyes, that lead to the kidneys, the large ones that lead to the heart, lead to the feet. And when I talk about diabetes and the sugar molecule, I like to use a example of like a marble going through a straw. And
Yeah.
if you're forcing that marble through that straw, it's destroying that straw. And so
Yeah.
that's the blood vessel, and that's the glucose or the sugar molecule that's going. And so I love the way that you describe the kidneys as being a rock and how it just chips at it. It just chips
Exactly.
at the kidneys. And when we talk about the progression of the signs and symptoms, when they get to you, and I believe it was when we spoke last time about this, you said typically people don't start noticing that something's wrong with their kidneys until it's at a certain percentage. What is that percentage of
It,
functioning?
sure, it can be as less as 25%. So you might have a situation where your kidneys are working at 20% or less, and you'll have no idea.
And
And
they're
when
walking around and don't even know.
have no idea, they have no idea. They're walking around, they have no idea. And that's the crazy thing about kidney disease, the same way it's a crazy thing about like high blood pressure, is that they don't have any symptoms.
Yeah.
And so by the time that something actually happens, they're like, what? You know? And another thing that's really interesting is that if you have a first degree relative that's been on dialysis, or you have or a first degree relative that's had kidney disease. And I think we spoke about this a little bit in the past as well, on our prior conversation, is that it's kind of important for us to know our family history, but
Yeah.
sometimes we are not very we don't,
Yeah.
that's their business. That's not our business. But I
Right.
think we have to get to the point where we know that that's all of our businesses, right?
Mhm. Yeah.
Um, because you have an increased likelihood of developing kidney disease yourself. So sometimes, just by having a family member that's had kidney disease, or been on dialysis or even transplant, that is something where you really, you should be made, be at heightened awareness that I need to get checked out.
Right.
I need to get checked out.
Yeah, and that's where it's important when we're doing that physical exam and we're doing the review of systems and the history that we're asking those questions about the family. Like,
Yeah,
what about your mom, your dad? What about your grandparents? Anybody in your family have these signs and symptoms? Because certain disease processes or certain conditions, if you have a family history of that, you are at a higher risk for developing those things as well. So we
definitely.
talked about diabetes. We talked about hypertension. What are some other things that could cause kidney damage or kidney failure and lead a person up to needing dialysis or transplant?
Sure. So one of the biggest ones is something called IgA nephropathy. And with IgA, it's actually a molecule that causes the membrane of the kidney to not work the way it should be. We tend to see those in younger patients.
Mhm.
And with IgA, they start to spill a lot of protein in their urine. And there's another condition called FSGS, which is focal segmental glomerulosclerosis, where it can be caused by high blood pressure.
Wow.
And they also start to spill a lot of protein in their urine. And how can you tell if you're spilling protein in your urine? Is when you go to the bathroom and it looks like you just basically dumped some dish soap into the toilet and you see all these bubbles.
Yeah.
That's a big sign that you're leaking protein, because you should not be leaking protein into the urine. Another one that's familial, especially in the African American population, is something we call polycystic kidney disease, and
Yes.
that's where, as opposed to having that nice healthy kidney tissue, you start to develop these like almost like these, I call them bubbles on the kidney, and they get bigger and bigger and cause the kidneys to be just enlarged. So right now, imagine, look at your fist, make a fist, and that's the size of your kidney, right? your kidneys, because you have to, right?
Yeah.
But with polycystic, we've seen kidneys weigh up to 20 pounds apiece, and they're just enlarged with these cysts, and that tends to be familial. So you'll have families. I've dialyzed families. I've transplanted families with polycystic kidney disease, and
Wow.
and that one is really interesting. The good thing is that with polycystic, usually polycystic will not reoccur in the transplanted kidney,
Okay, good.
right? So every so often you will have a situation where, like the IgA nephropathy, that can reoccur in the transplanted
Mhm.
kidney. Another one is lupus.
Yeah,
Lupus can damage the kidneys, and unfortunately, you got to feel for lupus patients because they go through so much.
definitely.
And what ends up happening with them is that by the time the lupus basically takes their kidney function away, the disease itself usually has burnt out, as we said. It's done all the body damage it
Yeah,
can do.
yeah.
And so what happens with them, usually when they get transplanted, they tend to do well. But those are the big ones. I would say the ones that we see most often are from, of course, diabetes, hypertension, polycystic kidney disease, IgA nephropathy. You tend to see in a very young population, and then focal segmental glomerulosclerosis, or we say FSGS, and lupus. The great thing with modern medicine is that we used to see a lot of kidney failure from HIV. So HIV itself can cause what we call HIV nephropathy, associated
Yeah.
nephropathy, where we have patients on dialysis because of their HIV. But
Mhm.
luckily now, because of the medications we have, we tend to see less and less in that,
Right.
right? And the great thing with HIV is that if the patient's able to manage their HIV and control their HIV, even if it does affect the kidneys, we are transplanting. I think most every transplant center will transplant an HIV patient.
Good. Good. That's amazing to hear because I can remember the days when that wasn't the case.
Yeah,
When that
very
was
recently, right? Yeah.
yeah. So when we were talking about some different values. When let's just say I have a patient come to me, I run routine blood work on them. There's some different values that I'm looking at to monitor their kidney health. And once things get to be, above normal ranges, then we're looking at referring them over to nephrology so
Right.
they can have further evaluation. When we're talking about blood work, what specifically are you all looking at in terms of qualifying a patient for a transplant? And we had a interesting conversation about this. So tell us a little bit about what you guys are looking for in terms of the numbers.
Sure. It's called the what we look at when you get your blood work. A lot of people look and see at something called the BUN, which is the blood urea nitrogen, and that shows how where the kidneys are clearing the waste products that we spoke about previously from the blood. And then we look at something called creatinine. And creatinine basically is the actual measure of the waste products the body that's being removed. So the lower the creatinine, the closer to normal it is. And the normal value is usually about zero point 0.5 to about 1.2, 1.3, just depending on the labs that you look at. Um, but the lower the number is, like the closer to normal you are, that means the kidneys are working well. They're getting rid of the waste products. So a lot of people look at creatinine level. But to make things more easier and more, so we can all speak the same language, so to speak, we look at something called your GFR, which stands for your glomerular filtration rate. So you heard me say it previously when I was talking about FSGS, when I was talking about focal segmental glomerular sclerosis. So
Mhm.
what a glomerular is, or glomerulus is, or glomeruli, is basically those are the actual functional units inside the kidney. And
Mhm.
so the more you have, the better your kidney function is, right? That's the goal. But what happens is that we want to see how well they're working. Now, when you're what we term it as a GFR, which is the estimated glomerular filtration. I can't even say it half myself. The R
You
filtration
me
rate
either,
is.
so don't feel bad.
So when you look at the GFR, it gives you a number, and then you can take that number and you can stage your kidney if you have kidney disease.
Mhm.
So we consider you to have kidney disease, anybody to have kidney disease, if that number happens to be 60 or less. And usually we're looking what would you consider normal? To be honest, anything greater than the 60, we of course when you keep an eye on it. but you don't really act on it. You might tell the patient to do certain things like make sure they're hydrated,
Right.
avoid certain medications. But when that EGFR becomes less than 60, that's when you really start paying attention to it.
Mm-hmm.
Now, I think the conversation we had that was interesting was that people who are of African descent have more muscle mass. And
Mm-hmm.
that's just a proven fact, right? So, what they used to do in that EGFR calculation is that they would calculate it differently for people of African descent. So, for example, if I'm a Caucasian female and I have a creatinine, because you use the creatinine and use the creatinine and the patient's age and their sex to kind of calculate the EGFR. So if I am a Caucasian female who happens to be, let's say, 65, and my creatinine is, let's say, within normal range of 1.2, my EGFR would actually come back much lower at closer to maybe 40. So that's clearly less than 60, and that would signify I have kidney disease. But if I'm an African American male who, let's say, is 30 and I have a creatinine of 1.2, when you calculate that, it would have come out to an EGFR of probably closer to 55, 58 or so. So, in other words, they did not recognize the fact that we had, they would automatically give us a higher GFR based on our
Right.
race.
Right.
Now, why is that? That sounds like, oh, okay, well, that's a plus for us if those of African descent. No, not necessarily. Because
Right.
as my kidneys worsen, so that little Caucasian lady who's 65, who now has a creatinine of, let's say, 2.5, may have an EGFR of closer to, let's say, 20. So 20 is pretty far into kidney disease, and that's what we actually would call severe kidney disease. She would actually qualify to be evaluated for a transplant.
Right.
But if I use the black male who now has an EGFR of, let's say, 2.5, guess what? I'm sorry, creatinine of 2.5, his EGFR might actually be closer to 40. And that would not qualify him for transplant.
Right.
So there was definitely a disparity when it came to transplanting people of African descent because of this increased muscle mass
Right.
calculation they added. Well, luckily, the powers
Mhm.
that be, their eyes were open and realized that was not the right thing to do. Because guess what, Dr. Wells, when we get sick as African Americans, we decompensate. We go downhill much quicker than
Mhm.
other people. So that would put me at a so the other, let's say the little Caucasian lady, she's been on the transplant list for probably about 3, 4 years, and she's getting close to getting a kidney. Whereas that other, the African American, was not allowed to be on the transplant list because of this, this calculation. Luckily, by the grace of God, that calculation is gone, and so we just calculate the EGFR based on your creatinine and basically your sex and your age. That's how we do it now.
That's amazing that that change was made because now it gives everyone a fair chance of being fairly evaluated for kidney.
Exactly.
Whereas
Exactly.
before there, like you said, there was such a disproportionate, and it was against, it wasn't in the favor of those who were of African descent. So I'm so glad that that was changed. I just
Yeah.
remember having that conversation with you, and you were very passionate about it, as should be, right?
Yeah.
But I think we're both grateful that that changed,
Right.
because that a great win for many of your patients. And if I'm remembering, I know you said once that was changed, they were able to go and do a look back at
Yeah.
some people who at one point weren't eligible for kidney transplant because they didn't meet the criteria. Now, once you get on the list for transplantation.
Exactly. And what they actually were able to do, and I was actually looking at a patient today where they were able to go back, look where they had added in that race component, and they're giving patients time back. So if I had so patients are getting up to like anywhere from 6 months up to 2 years back, and that makes a big difference on when it comes to
Yeah,
transplant.
it does.
And when it comes to, but what numbers do we look at? When do you get concerned if your EGFR, like I said, 60, we start kind of looking and say, oh, let's follow these certain things. Let's make sure your diabetes is controlled. Let's make sure your hypertension is controlled. But when you get usually less than 45, that's when you should or you could start looking at sending the patient to see a nephrologist.
Mm.
But the other thing that you look at is you look at the urine, because as we mentioned before, there's certain kidney disorders that cause you to spill protein into the urine, right? So I always look at the kidney as a tea bag, right? So I put the tea in the tea. I put the tea bag in the water. I make tea. That in essence is my urine, right? But what happens is that if I beat up on that tea bag and I misuse it and I kind of throw it around and I'm hard on it, it's going to start to tear and it's going to start to leak the tea leaves. The
Yeah.
tea leaves is protein.
Yeah.
You should not be losing protein through the urine. So a lot of times when you look at somebody's, let's say they have an EGFR of like say like 45 or less, and a lot of people will use something they call a microalbuminuria, and that will also give you a clue. So if they are spilling protein into the urine, then that is a clue that, yeah, you know what, their GFR is falling and they have protein in their urine. That's time for them to see a kidney
Yeah,
specialist.
something's going on, and we need to get them to the specialist so that they can be
Right.
evaluated. When we were talking last, I remember you speaking to dialysis
Yes.
and how to hear that you have to go on dialysis can be very scary. There's
Yeah.
a lot of unknowns. Um, and it's just a process that we have to carefully and take time to walk those patients through that process. Tell me a little bit about your that conversation you have with your patient who has to go on dialysis.
Yeah, you try to have that conversation before. What the last thing you want a patient to do is what we call crash into dialysis. That means they start to feel really sick, like those symptoms we mentioned. They're itchy, they're getting sick, not even by the sight of meat. They're short of breath. Why? Because their blood count is so low because the kidney's not making the hormone to help them make red blood cells, right? So what we try and tell our patients is we want you to be able to walk into a dialysis unit when you're ready to. We
Mhm.
don't want you to end up in an emergency room and we're putting a catheter in your chest and we're putting you on a machine. That's what we don't want for you.
Right.
So what we try to do is we start to have that conversation once the EGFR is about 25 or less. The first thing we talk about is what kind of dialysis would they be interested in?
Mhm.
Are they the kind of person that feels more comfortable going to a center 3 times a week and having somebody take care of them? Or are they the kind of patient that wants to do dialysis at home where we actually
Right.
put a tube into we say into the belly. It actually goes into what we call the peritoneal space, kind of close to the belly button.
Mhm.
And they basically, fill their abdomen or it's not their abdomen exactly, but it's their peritoneal space with fluid. And their body actually serves as a dialyzer. Peritoneal
Mhm.
dialysis, they do that at home. They do it as they sleep. A lot of patients who are on peritoneal dialysis travel the world.
Yeah.
They have so many options available to them. And now, more and more, we're getting to the point where patients are doing home hemodialysis, which means that we have machines that are literally the sizes of like very small refrigerators that
Wow.
you can just dialyze at home. And so you have to kind of assess and say, what do you want? Now, a lot of patients, when they think of dialysis, I don't know about you, Dr. Wells, but like they think about the fistula or the graft we put in their arm. And they're like, I don't want that big rope thing on my arm. That thing is ugly. It looks like a snake,
Mhm.
and I can totally respect that because that is a scary thing to have. Like, and when you touch it, it buzzes and it's like,
Yes.
zoom, zoom, zoom. And,
Is it the
so
thrill and brewing that you're
the
listening
thrill
and
of
you're
doing.
feeling for? Yeah. Yeah.
So they see that and it affects their body image. Oh my gosh, what are people going to think? And our goal is to assess them and say, hey, what do you want?
Right.
And they're going to say, well, I don't want to be on dialysis. Okay, well, unfortunately, we've passed that point. So we do have to talk about, we don't ever want our patients to be uninformed. We don't ever want them to be in a situation where they're saying, I didn't know this was going to happen. So if you can, you bring family members in. I know you had mentioned that you had a patient that was going to start dialysis and you had them talk to each other.
Yeah, so I had a patient who was going to go on dialysis who needed that, and I was able to connect her with another person who was actually in the process and had already been on dialysis. I can't speak to that because I've never gone through dialysis. And she was asking, what is it going to feel like? How is it going to make me feel afterwards? What's the process? I've seen it done, and I've been there when it's been started, but I don't know the life of someone going through dialysis. And so
Exactly.
I was able to connect those two individuals together, and that one connection and just taking time and that one person talking to this new dialysis patient formed into a lifelong friendship. And I have not talked to them in, a couple years, but they would keep in contact with me, and they were still best of buddies and best of friends because of that.
Yeah, see, I love that, and I just wish, and again, how I feel. I feel like that's something a nurse practitioner would do, because that's just that's very you're pulling into, yeah, the medical training you have plus your nursing, right?
Mhm.
And could you imagine a situation where that was happening more and more often? Could you imagine a situation where you had somebody who was there to say, hey, this is what's going to happen. I'm not going to lie to you. It's not the best feeling, but you're going to be okay.
Right.
Because sometimes that's all they need to hear.
That's all. That's all
Yeah,
they need to hear. And I think going that extra step, taking that extra few minutes to educate that patient, to talk with them, to hold their hand, to sit and listen to them, even if they have to vent or just cry. I think that, I don't know about you, but when I had an opportunity to go to medical school or NP was it all the way, because I love being a nurse,
yeah.
and we get to take that time. Not that doctors don't, and I'm not, throwing
Right.
it
No, I totally
against
understand.
any physicians. There are some amazing physicians out there, amazing DOs. But as a nurse, we have that background, and we're
Right.
able to bring that into advanced practice. And so to be able to do that it just means the world to me. And it's something that if it were my family member, I'd be doing the same thing, and I want the same thing done for them.
Yeah, it's very, and that's, I just think that's the advantage of being a nurse practitioner, because like I said, I was a dialysis nurse forever before I became an NP. And so today I actually had to cover the dialysis unit. And
Okay.
so I had a situation where the patient, the access, the fistula, it wasn't working the way it should. So I was like, oh, okay, well, let me go take a look. You go and you take a look, and it's something I had seen before. And I see, because of my dialysis nurse years.
Yeah.
And I looked at that patient and he looked so worried. I'm like, let me tell you a secret. We're going to do A, B, and C. But do I look stressed to you? If I'm not looking stressed to you, I don't want you to look stressed. I've
Right.
seen this before. We know how to work with this. It's going to be okay. And that's something that I think that is so important, that as nurse practitioners, we get to do that.
Yeah.
And so today I was like, oh, okay, because I was like, man, maybe I should just stick the fistula myself, like get it from here. But I was so tempted, but I was like, no, let me just, go about. But speaking of kidney disease, there is a whole group of new medications out. And those, and when I talk to my patients, they laugh at me because I also take care of chronic kidney disease patients too. And one of the medications that we're using more and more is a medication called Jardiance. And the patients say, are you talking about that commercial of that lady dancing? And I don't know if you've seen this commercial.
I have.
Okay. So that medication, pagliflozin, is kidney protective. So not only does it, if you have a patient that happens to be diabetic, and even in certain cases, we're given to patients who are high risk, but it protects the kidneys. And by giving the patient this medication, we've been able to kind of not almost halt their chronic kidney disease.
Hmm.
So we have more and more tools available to us now that we can use, and the goal is to not send our patients to dialysis. But if they do go, because dialysis is there, and dialysis definitely has its place, because transplant is not for everybody.
Right.
um, and but again, educating our patients that this is what you're going to do. You're going to go to dialysis, and you might find a friend and you all watch the same show, because daytime TV is a big deal in dialysis units.
Hmm.
So so just letting them know it's going to be okay. It's scary, you
Yeah.
know. I mean, it is scary.
There is life after dialysis. My dog, who's supposed to be in the front of the house, I kept trying to figure out who was opening the door because I didn't think I was the only human home, and she just opened the the door and came in the office. So that's why I kept looking.
Oh,
but she's in the office, but she's fine. But there is life after dialysis, and I think that there's life after kidney transplant, right?
There is. Oh yeah.
And
Um,
that's something that people need to hear.
yes.
Um, if you had to leave us with three important keys or three important things in regards to kidney health, what would that be?
Number one would be know your numbers. Know your numbers. Know your blood pressure. If you're diabetic, know your A1C. Know your numbers. If something's a little bit off, don't be afraid to ask. And we totally believe in white coat hypertension. Like when you go into the doctor's office,
Yeah, we
your
say
blood pressure goes up. We know that, we relate to that, but know your numbers. Number one. Number two is don't be afraid to go to your provider, right? Because every so often you'll go into the Publix, you'll see somebody checking their blood pressure, but you wonder, do they have a provider they go to? And
it.
that's
Right.
why, again, I mean, I'm so proud of you with your practice and everything,
Thank
because
you.
I think that you bring something, when patients come to see, they know they're getting you. And again, we're not bashing physicians in any way, shape, or form, but it's just something different about how we practice as nurse practitioners. We're not physicians, we are nurse practitioners with doctorates, and we
Yes.
practice differently, right?
Yes.
So get with a provider, get with somebody you trust, get with somebody that you know that you can speak to and you're not embarrassed. That's probably the biggest thing. Don't be embarrassed to tell your provider anything, because we've heard it probably all, and we're just
Right.
going to look at you and say, okay, well, let's do A, B, or C, right?
Yeah. Yeah.
um, and I think the last thing that I would say as far as kidney health, and I think we mentioned this during our last conversation, is hydrate. Hydrate. And it's not that dehydration, prolonged dehydration, yeah, will cause acute kidney injury, whatever. But hydrate. Don't be afraid of water. And the reason I say that is because you get just so many more benefits out of it. It energizes you. um, Hydrate. And of course, I think I told you, I'm anti soda,
Yeah.
um, especially dark sodas, dark
Yes.
color sodas, because they're high in what we call phosphates, and phosphates
Mhm.
have been shown to adversely affect the kidneys long term. So if you're somebody who's like a Diet Coke drinker, like I have a good friend, and she can't live without her Diet Coke. And I
Yeah.
looked, and the little girls, like she has 10-year-old girls, and they were drinking Diet Coke, and I was like,
Oh,
whoa, 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 okay, we got to have a discussion here.
yeah.
um, but hydrate, learn to drink water. I want, my dream is for everybody's pee to be, like, it doesn't have to be crystal clear, but to
Right.
be, a nice pale yellow.
Yeah.
When you're thirsty, drink something that is non-caloric, non-caffeinated. I think that is just like one of the best things we can do. And I don't think that we emphasize that enough. People say, well, it's good for your hair, it's good for your skin, but it's also good for everything in your body.
It is most definitely. And I know I tell whenever I'm having a conversation with someone and I'm asking about their diet and their habits and what they eat and what they drink. And whenever someone tells me that, they drink soda, any type, I say, okay, for every soda you drink, I want you to drink a bottle of water,
Yeah.
to chase that soda because we need to
Mhm.
wash that out so it's not impacting your kidneys. It's so important. One, just to stay hydrated, one, to know your numbers, and then don't be afraid to see your healthcare provider because we want to be a society that's proactive versus reactive. And many of
Exactly.
the times we see patients primarily with kidney disease because they weren't proactive. And now we're having to react to and chase the damage and hoping that we can get them back to some sort of normalcy when it comes to their numbers for their kidneys. Um,
Exactly.
I'm just amazed. But anything else you want to share with us tonight?
Just that, I'll tell you this, what's really exciting that's going on is, I don't know if you saw this in the news, but we have patients that go on transplant lists, and they can be on a transplant list for up to 10 years
Yeah.
before they're transplanted, right? We're a little bit more fortunate in the state of Florida. We have our numbers for transplant a little bit less. We have shorter wait times in the state
Okay.
of Florida. They just successfully transplanted a patient with a pig's kidney.
Oh, no, I didn't see that.
Yeah, there's a lot of research going on
Oh,
with pig transplanting patients with pigs' kidneys, and these are specially raised, genetically modified pigs. And they did a couple of different things to these pigs where they've actually knocked out two of the genes. I can't remember the other one, but one of the genes is to prevent the kidney, to keep it human size.
oh,
And patients still have to take their transplant medications, because you take medications so your body will think that that new kidney we put into it is has always been there, and that's why you take the
right.
transplant medications, is to trick your body. But so far, they had one successful. He was transplanted with a pig's kidney, and as far as I've heard, he's doing quite well.
Oh, that's amazing.
So I'm very excited about that, because could
That
that
is
possibly mean that in the future that that there won't be these horribly long wait lists for
right.
organs? And remember, they were using like baboon hearts in the
Yes,
past, and they were
yes.
using, and unfortunately there was a lot of there was fear of transmission of certain viruses, right?
Mhm.
So that was not necessarily the best idea. But now I'm really, really hopeful for these pig kidneys.
Oh,
And
that's amazing.
I'm so excited to see what the next few years hold, because I think that could really change lives. And people who are probably never going to get transplanted may be getting transplanted. So dialysis will still be there, but it'll be there for that specific population that maybe is not,
Right.
acceptable for transplant. And it's not because we don't have an organ to give you that you have to go on dialysis.
That's amazing. Thank you for sharing that. I had not. I have to go and check that out and do some research. But that's amazing. That is a step forward in the right direction for patients who have been on a list and who so
Yeah.
desperately need kidneys.
Yeah.
So,
So
Dr.
excited.
Alma, I just want to say, Diva. I'm gonna throw that in there. I just want to say thank you so much for being here. I'll just share. Dr. Alma and I recorded this. I want to say last week or
We
something, and we had some technical issues, and I just could not post that. It was a great conversation, but I wanted to make sure that I am sharing you in the best light and
are.
that we don't have any issues. And tonight was beautiful. So are you. Thank you so
Oh,
much for your time.
thank
Thank you for all
you.
you do for our community and the patients that you serve and the veterans. This is Dr. Latoya Wells and Dr. Amma Seewah-Bonsu, nurse practitioners who hold Doctor of Nursing practice degrees. And I just want to say, stay safe and be well. We'll see you next week for another episode of Wellness Wednesday with Dr. Wells. Take care.
Bye.
Bye.
How do I disconnect?